Welcome everyone to this Mental Health for All webinar brought to you by United for Global Mental Health, Lancet Psychiatry, Mental Health Innovation Network, MHPSS.net, and the Global Mental Health Action Network. My name is David Bryden. I'm the Tuberculosis Advocacy Officer at Results based in Washington, D.C. in the U.S. and very happy to be with everyone today. The session is being recorded. Please use the hashtag #MHF for all. That's #MHF for all when tweeting about this webinar. Please do tweet throughout the webinar to spread the word about this session. The session will last about 45 minutes, and do send any questions to webinars@unitedgmh.org. Webinars@unitedgmh.org, or write them in the chat box. Look on your screen, you'll see the chat box there, and just type in your question. Be thinking about your questions because we do have a question session at the end, so get some questions ready. You know, this is an absolutely critical issue when it comes to the success of Global Fund grants. And anyone writing a proposal to the Global Fund has got to take these issues into account of mental health. If you just look at TB, for instance, mental health conditions are associated with poor TB outcomes, and depression is strongly associated with loss to follow-up and non-adherence to TB treatment. Yet only 2% of TB programs around the world are providing access to routine mental health screening. That's just to take the TB example. Obviously, with HIV, we have a similar situation. But fortunately, people are taking action, and we've got some fantastic panelists here who are going to walk us through what practically we can do to address this issue and this critical gap. We have Neerja Chowdhary, who's a technical officer in the Department of Mental Health and Substance Abuse at the World Health Organization. She's a psychiatrist by training. Her areas of work include the provision of technical assistance to WHO's Mental Health Global Gap Action Program. We have Vongai Munatsi, who's a clinical psychologist who lives and works in Harare, Zimbabwe, and she's currently the mental health specialist at Africade Zvandiri, a community-based organization that supports children, adolescents, and young people living with HIV. We also have Dr. Ethel Nakimuli-Mpungu, who is a senior lecturer and psychiatric epidemiologist at Makerere University in Uganda. And she has developed a highly cost-effective group support psychotherapy program that can be delivered by lay health workers, which has been shown to dramatically reduce depression symptoms and improve outcomes. And we also have Aneeta Pasha from IRD. And IRD was the technical advisor to the Indus Health Network, which was the recipient of a large Global Fund grant in 2017. She established IRD's mental health program in 2014 and is leading on the integration of mental health within the TB work. So we've got some fantastic technical experts here and practitioners. And we're going to go through a couple of questions. We're going to have 2 rounds of questions, and then we're going to open it up to your questions. So get those ready. So, we're going to start with Neerja Chowdhary with the WHO. Neerja, can you tell us about what is the WHO doing to ensure that mental health is a part of the response to HIV and TB?
Thanks a lot, David, for your question. And let me begin by saying how happy I am to be a part of this great panel and today's webinar. David, you very aptly began with reminding us about the importance of this topic and why mental health, it's important to address it within the HIV and TB response. In fact, we know that if we have to achieve the Sustainable Developmental Goal of ending the HIV and TB epidemics by 2030, we cannot do this without addressing mental health. Also, the WHO TB strategy explicitly calls for tuberculosis and mental health treatment to be integrated. And especially, we know this is important when we think about person-centered care. But the good news here is really that there are several cost-effective, evidence-based community mental health interventions that can be delivered to improve outcomes for mental health, but also for HIV and TB. WHO has developed norms, standards, as well as technical tools to support countries to address mental health, HIV, and TB in an integrated manner. Let me describe some of these to you. The first is the MHCAP guidelines for mental, neurological, and substance use conditions. And these provide evidence-based psychological as well as medical interventions that can be delivered effectively by non-specialists, including those working with HIV and TB programs, to address mental health within their programs. There are also tools for the prevention and treatment of alcohol and drug use disorders, such as the brief interventions for alcohol, the community management of opioid overdose. There are guidelines for the management of physical health conditions in people with severe mental disorders. Let's not forget the unfortunate reality that people with severe mental disorders, such as psychosis and severe depression and bipolar disorder, die 10 to 20 years earlier than the general population. And this is largely because of treatable and preventable conditions, including HIV and TB. There are also consolidated guidelines for the use of antiretroviral drugs for treatment of HIV, and guidelines for the treatment of drug-resistant as well as drug-susceptible TB, all of which address adherence support interventions and psychosocial management for mental health conditions, including depression, alcohol, and drug use disorders. We have several opportunities ahead of us. Let me speak about three. One is the umbrella of universal health coverage, which provides us the umbrella under which we can address comorbidities, including leaving no one behind. The other opportunity is WHO's Comprehensive Mental Health Action Plan, which has now been extended to 2030, and that in fact underlies the importance of integration of mental health in primary care. And finally is that this week, the board of the Global Fund is meeting to discuss its new strategies for the years to come. And this provides us a unique opportunity to ensure that mental health is an integral part of the global response to HIV and TB. WHO has worked in collaboration with UNAIDS, in fact, over the last year to discuss support to countries relating to the Global Fund funding requests. And there's been a peer review workshop which was organized in Nairobi earlier in the year. And this has been followed by multidisciplinary expert remote desk reviews, in which WHO's mental health department has been an active participant, including both at headquarters as well as the regional office, to review proposals and provide detailed feedback, including specific recommendations to the country teams where and how mental health can be addressed in these proposals to the Global Fund. We also know that having guidelines is not enough, and countries need support in knowing how to integrate mental health into their HIV and TB programs. And to this end, WHO and UNAIDS are now developing an implementation guide to support countries in their efforts for integration. Thanks, David. I'll stop here now.
Thanks. It's really helpful comments. And I think that, if you're wondering if the WHO is clear about this, this answers the question. The WHO has very clear guidance on this. And I'd like to just add that the Global Fund expects applicants to be presenting proposals that are patient-centered. And patient-centered programs have to include mental health. So let's look at some practical examples of how this is actually working in the field. Let's turn to Vongai Munatsi from Zimbabwe. Can you tell us about the READY movement and how does it work to address the specific mental health needs of adolescents and young people living with HIV?
Hey, technology, I have unmuted myself.
There you go. Okay.
Thank you, David. I think this is such a powerful webinar, and I'm grateful that we've had this opportunity to talk about mental health, particularly looking at children, adolescents, and young people that are living with HIV and who are some of the most affected by mental health challenges and who stop adhering to their medication because of undiagnosed and untreated depression. And this leads to virological failure and all of these other challenges that you'd already spoken about, David. So with the READY movement, it's a consortium or partnership of organizations and youth leaders that come together to talk about HIV and to come up with interventions that support children, adolescents, and young people that are living with HIV. And an example of that is that the Ready Plus movement, supported by the Dutch government, has been working in 4 Southern African countries to support children, adolescents, and young people living with HIV with interventions that support mental health. So there is a lot of training of peer supporters that then follow up on their beneficiaries or other peers that are living with HIV, as with the Jandiri program, where CATS or community adolescent treatment supporters are trained and are equipped on counseling skills and also how to screen for common mental health conditions. And then they go into the community and they follow up their peers. So they work from facilities, which is the healthcare facilities they're integrated into the different ministries of health of these 4 countries that I've mentioned. And from there, they visit their peers within their homes. They conduct home visits. They also follow them up at facility level to find out how many have defaulted on their medication and how many are facing mental health challenges. And through the screening process that they do, they then provide counseling support to those that they can support. And they also refer them onwards to other practitioners that can then provide support or give them further support, particularly for those that have psychosis or other conditions that would actually need a practitioner to help them. The Ready Plus movement has also been advocating and campaigning for mental health services for different age groups and for African countries to start recognizing the importance of mental health in supporting children, adolescents, and young people that are HIV positive. I would say that's the practical work that we are doing, David.
Fantastic example of taking this concern and putting it into real action. So that's great to hear about what you're doing there. Now I want to just turn to Uganda and hear from Dr. Ethel Nakimuli-Mpungu. Ethel, can you tell us about your work in Uganda and training health workers in psychotherapy?
Absolutely, David. Thank you for your kind introduction. Good morning, good afternoon, ladies and gentlemen. Well, 8 years ago, we developed group support psychotherapy to narrow the treatment gap for depression, in particular in rural communities, for persons living with HIV/AIDS. So in a pilot randomized trial, we were able to test this intervention and found it to be highly effective against depression. So after this success, we teamed up with the Ministry of Health to make this therapy accessible to individuals in the rural communities. And so we rolled it out across 3 districts in northern Uganda. And we did this using the training of trainer model, whereby we went into the various health centers and talked to the health center managers and asked them to nominate health workers that we could train, health workers that have interest to learn this new skill of identifying depression and treating it with a first-line psychological treatment. So the nominated health workers were then invited to participate in a 5-day training. And after this training, they're then required to participate in a practical training, which involves going back to your health center and convening group support psychotherapy sessions. So these sessions were supervised by us, the specialists, together with other mental health workers we had trained earlier. And so a health worker had to identify a group of individuals with depression, for example, like 6 to 8, and take them through the group therapy sessions while being supervised. So a health worker who managed to do this then qualified to be able to train lay health workers. So the lay health workers are trained at the health facility, and this training takes place in the local language, and it's done by the trained health workers, of course with supervision from us, the specialists. So then the trained lay health workers are able to go into the the villages, be able to give a health talk on depression, and then invite individuals for further evaluation. And those who are found to have depression are then invited to participate in the group support psychotherapy sessions in the villages. So in this way, we're able to bring the therapy closer to people. And so we were able to also evaluate this in a large cluster randomized trial, again, where we saw that it was highly effective against depression. Individuals achieved remission 6 months after treatment, and were able to stay depression-free even up to 24 months after treatment. We have done more evaluations of this intervention, and we actually found that in the long term, treating depression with group support psychotherapy was able to improve adherence in persons living with HIV/AIDS and also improve their viral load.
That's great to hear. You've shown some real empirical evidence of the success of your intervention, and so it's really a great example for us to look to. So I'm going to turn now to Aneeta Pasha with IRD in Pakistan. Now, in terms of your work as the technical advisor for mental health for the Indus Health Network, which is the recipient of a large global fund grant in 2017, how did you ensure that mental health was included in Indus's work on TB?
Thank you, David, and thank you for inviting us to this panel. So we initially started, also the mental health program started using a lay counseling model similar to what has been described by the previous panelists. In early 2017, when the conversation was going, or the negotiation was happening with Global Fund, what really helped us to integrate mental health was the fact that we had some pilot data where we had looked at the prevalence of depression and anxiety amongst TB patients. And we used that preliminary data during the course of those conversations with the Global Fund to demonstrate that there was a dire need for mental health for TB patients. So we had about a 30 to 40% prevalence of depression and anxiety in newly diagnosed TB patients. In addition, around that time, there was also a WHO guideline, one line in one of the documents saying, stressing the need for psychosocial interventions and holistic care around patient-centered care. So coupled with that, we use that to kind of say, look, here's an evidence-based intervention that we would like to pilot within the Global Fund grant, which is why we were able to integrate within that. The focus at that time was far more on drug-resistant TB than DS-TB. There was an interest in psychosocial interventions around that, but we made sure that our counseling interventions, which are also delivered by lay counselors, were available to DS-TB patients as well. GF did later discontinue funding for the mental health integration, and I think one of the reasons for that was the heavy interest in showing outcomes, mental health outcomes, which we all know take a longer time to demonstrate, right? Because mental health it's not a short-term intervention, and outcomes and impact tend to be seen over a longer duration of time. But we did still continue to make sure that we were able to continue providing the services to all of the patients, DS-TB and DR-TB patients. But since then, what we wanted to do was generate the evidence pointing to the impact of integrating mental health within TB facilities. So we conducted a research study over the period of 2 years where we used our task shifting approach using lay counselors to integrate mental health within, as part of Global Fund, but also a little bit extended beyond that, within 6 integrated practice units across public and private hospital settings in Karachi. And essentially how that worked was that every time a TB patient walked in and was diagnosed, we made sure that there was a counselor who would deliver 4 to 6 counseling sessions. And these were timed with whenever the patient would come in to see the doctor or pick up the medications. So over the course of 2 years, what we found was incredibly interesting, which I think we want to use now to advocate further for the integration of mental health services, is that of all of the symptomatic patients who completed the mental health intervention, 93% of them completed their TB treatment. And this was compared to the symptomatic individuals who did not complete the mental health intervention, who only had a 75% TB completion rate. So this is really incredible to demonstrate that the mental health intervention does have significant impact on TB treatment completion rates.
I just think it's so exciting that you've really seen that dramatic an impact in terms of treatment completion through your intervention, and that you've gone beyond not simply the drug-resistant TB patients, but also drug-sensitive. So that's really just taking it to another level, and very exciting work that you're doing. So I hope everyone on the webinar is gathering your questions. We're going to turn to those soon, but first we have a couple more questions for our guest panelists here. So I'm going to come back to Neerja Chowdhary with the World Health Organization. You're about to publish an implementation guide for integrating mental health services into HIV services. So what are some of the main suggestions in that guide in terms of integrating mental health into the HIV response?
Thanks again, David, and it's been really interesting hearing the real field examples of where integration has been attempted. We are developing this guide that I mentioned earlier along with UNAIDS, and our belief is that when we integrate mental health support in services for HIV, it will not only lead to better health for people with HIV, but also improve global access to mental health care, which is also, as we all know, very much needed. The guide seeks to serve as an accessible reference document to support the practical integration of the evidence-based interventions that I mentioned earlier into existing HIV programs, and it draws on these existing guidelines and is being developed along with global experts and partners in the field. We know, and we've heard from some of the examples already mentioned, that there are many opportunities for integrating services, mental health services into HIV, but also TB programs. And these are across the prevention, testing, as well as the care continuums. And the mental health interventions that we can integrate are, for example, for health promotion, there are stigma reduction, awareness campaigns involving people with HIV and mental health, and also illness prevention interventions, suicide prevention, adolescent mental health programs, as well as management and recovery for people with mental illness. And we heard about some of the psychosocial and psychological interventions that are being integrated. Also, these interventions need to address children as well as adolescents and families, and also key populations and vulnerable populations. Let's go into the principles for integrating mental health into the HIV and TB programs that the guide speaks about, but also some of what we've already heard from the other participants on the panel. It's important, firstly, to have right-based policies and plans to incorporate mental health into these programs for HIV and TB. It's important to have advocacy to shift attitudes and behaviors towards people with these conditions. It's important to have training for HIV and TB workers as well as for primary care workers, both in the pre-service curriculum as well as in-service training, and they need to be given ongoing support. And we heard of an example from Uganda of how this is being done. Also, we need to remember that these tasks that the primary care and the HIV and TB health workers do should be limited and doable. We know that they're dealing with a lot of other activities that they also need to conduct. Therefore, they need specialist mental health professionals to support them. We also need to ensure access to essential psychotropic medicines in HIV and TB care facilities and primary care, and also access to psychological treatments, which we know we have evidence that these can be delivered by non-mental health specialists. Collaboration needs to occur across different government non-health sectors, NGOs, village and community health workers, as well as volunteers. And we need, last but not the least, financial and human resources. So basically what we need is a commitment and shared goals from TB, HIV, mental health, as well as substance use treatment services to ensure that these integrated services are successful as well as sustainable. Thanks, David.
Yeah, thank you very much. I know we're all looking forward to that guide that's coming out. And let's turn again to some of the community-based examples and what's actually happening in countries. I'm going to turn to Vongai Munatsi again in Zimbabwe, who's working at the community level in particular with young people. What are the roles, as you see it, what are the roles that young people can play in supporting the mental health of their peers? And what are some of the limitations of those roles?
Okay, thanks, David. I think as we're all talking about integrating and we're talking about mental health services being delivered by lay healthcare workers, as we know that mostly in Africa and in Zimbabwe, we do not have a lot of mental health practitioners. Actually, our statistics are, you know, 1 psychiatrist to 1 million people. And so for people to get those services, it's actually quite difficult, particularly within, you know, within HIV itself. There's very few psychologists or mental health practitioners that are, you know, helping people. And so you find that the role of peer supporters is great in that they are a resource that we can tap into, in that we can train them on mental health interventions that they can actually deliver to their peers. And right now in Zimbabwe, with the Ready Plus Consortium and through Zhandiri, our cats are trained to screen for common mental health conditions, including substance abuse and depression. I think one of the common ones as well is anxiety and trauma. So they are trained to screen for those in their peers. They also are trained to identify those that are at risk for common mental health conditions, and also to give support. So they've learned the basics of psychological first aid to be able to assist someone if they're suicidal or if they've got depressive symptoms. They also then know when to refer and who to refer to, and how to follow up on those referrals to ensure that their peers and their beneficiaries also get support. They've also been quite a good tool in terms of advocacy and putting information out there about mental health, because, you know, the millennials somewhere somehow have learned to take away the stigma that's sort of associated with mental illness. And it's very cool to have issues, you know, in this generation. So they can be a tool that can actually be used to reduce stigma, to reduce discrimination around mental health and mental illness. Which also then would become worse if somebody is already HIV positive. So I'm HIV positive and I now have a mental health condition, and there's stigma in both. And so peer supporters can also be used in that role. Their limitations, however, is that young people, because of you know, their developmental age and stage, they are very susceptible and vulnerable to common mental health conditions themselves. And I think one of the things that Chowdhary was talking about in terms of self-care and also providing that self-care for them is actually very important, in that they are an important tool and an important resource that we need to actually invest in supporting and providing self-care to. I think a lot of the times people and the donor community can sometimes think that, you know, peer supporters, because they are role models, and I call it the role model syndrome, they must not have a bad day, they must not have an off day. And it's actually impossible for a person to not have an off day. And because they're young people that are also vulnerable to all of these things around peer pressure, they will have an off day, and we need to be able to roll with the punches and support them whilst they're having their off day, and also be able to support them to continue in their role as peer supporters, because they have such an important role, and they can be used quite powerfully to support beneficiaries with mental health challenges. Thanks, Dave.
Yeah, thank you. I think that's so important. Young people are a tremendous resource. We need to work with young people and involve them and be sensitive to their concerns. So let's look at a few more practical situations and examples here. Turning back to Uganda and to Ethel, if you look at the program that you've been working at, have you seen an increased demand for this kind of low resource, scalable intervention? And what do we need to consider as we're trying to make these kinds of programs more accessible?
Yeah, thank you, David. Yes, since we published results from our large cluster randomized trial, many small organizations, NGOs have been interested in group support psychotherapy. We have two small organizations in Mukono district. This is a central district that did contract us this year to train health workers in health centers to learn this skill, how to identify depression and treat with group support psychotherapy. Unfortunately, for one of these projects, when the COVID came, the COVID pandemic, the COVID lockdowns came in Uganda. One of these projects, did not take off, but the other one did take off. And people, even within the lockdown, people still came to the group sessions because they were finding them beneficial, given the circumstances that were happening then. So we also have researchers who are opting to use group support psychotherapy. We have a researcher from Minnesota University investigating severe depression, and we're now able to give the participants the complete treatment package, medications with psychotherapy, and we're using group support psychotherapy. This project has enabled us to train health workers in 3 health centers in Kampala of 20 health workers to get the skill to give health talks on depression. Health workers in the health centers, they don't know how to give a health talk on depression. Actually, they've never. It's when we come in to train them, then they start to talk about depression to the people coming to the health center. So then people start to learn about this depression and to recognize it in themselves. But otherwise, there's a lack of knowledge about these common mental health problems. So now, when they are able to identify the individuals with depression, they now have therapy which they can offer. But previously, the health workers told me, yes, doctor, screening has been introduced in the health centers, but what do we do with the patients that we screen for depression? They don't have an intervention. So with group support psychotherapy, they can then offer that. And again, the patients have been very responsive and receptive towards the therapy. So our challenge is when the therapy and they improve dramatically, the health centers, they want us to continue, but this needs funding, so they have to find a way in getting the funds to support this therapy continuously. So we also have another foundation who, this is Child Relief International Foundation. They have offered us a grant to adapt group support psychotherapy for young people with HIV/AIDS. So again, this work is going on in northern Uganda as well as in Kampala district. We're trying to see how we can adapt this for young people and then again evaluate and see if they get the same benefit as the adults have achieved. The Ministry of Health has also approached me. Basically, they are looking for co-funders, funders that they can team with to get this intervention, not just at the health centers, heads of regional hospitals, they feel that their health workers also need this kind of skill, and that this intervention should be available even at regional hospitals. Yes, so they told me they were looking for co-funders. The Ministry of Health can, come up with something, but also if they could get another funder, that would make the work more easier for them.
Okay, thank you. I think you raised the really critical issue of funding, so we're going to have to come back to that in a moment. But before we do that, I just want to get a few brief comments from Aneeta Pasha from IRD in Pakistan. Could you tell us a little bit more about some of the specific mental health interventions that you found to be successful? And if I could just squeeze in one of my own questions, which was kind of referencing what Ethel was just talking about, was it a challenge to make sure that these were included in the proposal to the Global Fund? Has funding been sufficient?
So I think there are 4 key interventions in my experience that have been really critical for the integration for TB. So the first one is integration within the existing TB programs. So what we did is that we made sure that the mental health counseling sessions were aligned with the TB treatment appointments, thus reducing the need for the patient to come again separately for a counseling session, because at least we know in our context, patients who are very sick and very poor will not come back all the way to the facility just for a mental health appointment. So we made sure that the counselor would know when the next appointment was, when they were calling the patient back, and made sure that to expect them on the day that they're supposed to come in, and make sure that that second, third, fourth sessions are held on that day. The second thing that we found to be important is to ensure that the mental health counselor is, so the intervention is incorporated within the process flow of the clinic or the facility in which we were integrating. So, if the patient comes in, they get themselves registered, they go for vitals, they speak to the counselor, and then they go to see the doctor. So they don't need to go to a separate place to speak to the counselor. It's very much a step in the process as part of their regular appointments and as part of their regular TB treatment. The third thing that is really critical was the buy-in of the doctors and healthcare practitioners at the facility, whether that is the nurses, the site managers, the treatment coordinators, whoever is there as part of the TB program, all need to be encouraging the mental health check-in for the patient, especially in larger hospitals and larger facilities where the patient may get lost or doesn't make that effort to go to the counselor. So the reinforcement from the doctors and treatment coordinators to visit the mental health counselor was really important for us, especially because there is mistrust towards healthcare practitioners. Sometimes there's a lot of stigma, there's a lot of taboo. And so to have somebody say that this is important for you to make sure you go and speak to the counselor, we found was really important as well. Also, in our context, medical personnel are seen as authority figures sometimes. And so having somebody say that you need to do this is as important as your physical health has really been important for the success of the program. The last thing that we have found in our work is outside of the facilities, but more so at the communities, especially since Pakistan is also one of the places where we're doing the NTB clinical trial for the new TB drugs. And we've done a pilot with the community by setting up community advisory groups. And what these groups have are, again, out in the community, it's got representation from patients, it's got representation from supporters, it's got representation from the research team. And these are groups in the community that actually sort of critically engage with the trial, with what's happening. They are our link to the communities to understand what perceptions are, what the taboos are, what the stigmas are. And we found it's really been incredible to see the way the communities have engaged. So, it's kind of stepping away from the traditional top-down biomedical model, which kind of steps in and says you need to do these things. And it's kind of saying, tell us your experience with this. How are you, what are you thinking about TB? What are some of the challenges you may be having? And address some of the questions and take time with communities. So these are 5 key points that I think have really made an impact on the quality of care we are able to give to our TB patients.
Okay, and what are some of the challenges that you faced in ensuring that mental health was included in the proposal to the fund? This is something relatively new. Maybe not all national TB program managers are familiar with it. As you said, this is in some ways a departure from the traditional biomedical model. Was it all smooth sailing in working with the writers of the actual proposal?
I think, like I said, I think for us it was important to show the evidence, but I think the larger challenge was not at the time of writing, because we had buy-in at the senior leadership level. I think the challenge for us has been the continued support for funding. As I said, the interest was to show immediate impact and show immediate outcomes, which sometimes take more time with mental health, right? And so for that, the challenge was to kind of convince them that this is something that has value. So the value portion, demonstrating that value now, after all the research and the data we've collected over the years, we have that, and we are in a place to say this is what the value is. But at that time, before Global Fund discontinued the funding, I think that was one of the challenges, to hope that they would continue the support. One of the other things I'm going to touch upon very briefly that I didn't mention earlier was, as part of the generating evidence to show impact, we've also done time-driven activity-based costing study to look at the additional time and cost it takes to integrate mental health services. And the purposes of that is, again, for advocacy, to make the case to say, look at the impact that we are showing, but also look at the resources that are required to go into this. So we're just in the process of analyzing this data, and I hope very soon we will be able to publish this. But I think data such as that and evidence such as that is critical for sustained funding.
Yeah, that's a really good point. And I think it gets actually to some of the questions that have been coming in from the audience. We've had a lot of questions that have been submitted, so we'll do our best to get through at least a few of them. There's been a huge amount of interest in any published research or any specific documentation of your efforts across Africa and in Pakistan as well. And here's a specific question that one of you may be able to discuss, which is how has COVID-19 affected your work? And what have you done to mitigate any of the challenges that have arisen as a result of COVID-19 in terms of the actual implementation of the mental health services or the mental health condition of the people, the communities that you're working with? Anyone have any thoughts on that they'd like to share?
I can start.
Okay.
So Pakistan also went into lockdown in April of this year. And it was a new thing for everybody, I think, globally. And it was a complete shutdown. So I think one of the biggest impacts on the patient population was the fact that they could no longer access treatment, which we know is the case. So what we did is we pivoted our mental health program. We had all of our counselors who were trained, who were now also in lockdown, but obviously had the service to give. So we pivoted the program to set up a helpline. And what we did then is ask people to call in for mental health counseling and mental health support. So it included crisis support, obviously, because in lockdown there was increased levels of anxiety and depression, and this was open to the general public. The second thing we did was also establish a proactive helpline, and this is for COVID patients specifically. We, in partnership with the Indus Hospital that was leading the efforts for COVID testing in Karachi, what we did is we would call patients who had tested for COVID, whether negative or positive. And for positive patients, we made sure we call them every 2 days for the duration of their isolation, which was 14 days. And the purpose of this was to check in, how are they doing, especially because, you know, in the Pakistani context, there are often 8-10 family members living in a 2-room house, and now they were being asked to isolate themselves completely. And there's a fear, this is new for a lot of people. How do we isolate? What does quarantine mean? What is the correct way to do it? So we would talk them through that, as well as make sure they weren't worsening symptoms. If they were, we could guide them on where they could go, especially if they needed oxygen, and also for contact tracing. So what that allowed us to do since COVID has started, I believe we've called over 30,000 people. And that's an incredible amount of data that we have, but what that also allows us to do is call people who may have comorbidities. So they may have TB or any other illnesses, but also now have been tested for TB. And so that has allowed us to continue to provide them mental health support through our helpline.
Okay, that's fantastic. Way in which you've adapted your programs to the current context of COVID-19. Let's see. I've got some other questions here that delve into the costing of these interventions. How does the model that you've developed differ in scale and affordability in comparison to the more traditional model of psychologist and psychiatrist? I think that's a good question for Ethel. Do you have any thoughts that you could share about that?
Thank you, David. So that's a very good question. So we were able to assess for the cost effectiveness of our intervention in the context in which it was delivered, and our analysis showed that the intervention was more cost effective than the control intervention. The control intervention was group HIV education, and we know that HIV education continuously takes place in the HIV centers. So we used that as our control. So because we used lay health workers who we gave financial incentive, whenever they, led a group of people with depression, we found that whole therapy more cost-effective than the control intervention. And the analysis showed that even though the costs that we spent then were to be multiplied by 100, the intervention would still be cost-effective, given the impact it had on the individuals. We have not compared this with the traditional methods of using a psychologist or a psychiatrist, but in that context of the rural community, comparing a psychotherapy with an HIV education intervention, the therapy was found to be more cost-effective.
That's great to hear. There's been some excitement on the chat function here in the chat window about your work. We have Tom, who's written in from Agago district, or who has a partner based in Agago district in northern Uganda, who's very interested in what you're doing and wants to hear more about it. So we'll have to connect you later on. Yeah, so that's great to see.
We've always wanted to go to Agago district.
Okay, fantastic. So as you look at, here's another good question. When it comes to implementation, what have you learned is the most important for buy-in among clinicians in terms of integrating mental health? Can you talk about the issues of attrition? So people starting into a mental health program as a member of the community in the affected population, but then dropping out. So there's a question about attrition and about the clinicians. How do you get them to really participate in this these kinds of interventions? Any thoughts that panelists could share?
Me?
Yeah,
me,
or anyone
Ethel?
else on the panel? Okay.
Okay. Yeah, so really about the health workers, we have to select health workers who have interest in learning a new skill. Remember, these could be midwives, they could be social workers, they could be general nurses, but someone has to have the interest. Someone has to have the interest to gain this new skill, these new mental health skills, and is willing to help people and has commitment and will be able to train others. So it is not just about selecting any health worker. That is so important. And also it's disadvantageous when you bring in external health workers. For example, you use a private company organization and bring in counselors who are not in the community, who people do not know. The bonding between the health worker and the community members is so important. So if you can get that right and you get the health workers who are really committed, who have interest, but then also get the stakeholders, the health center managers, to allow them, to give them permission, to go into this new area. Because if you don't, then you may train them and then they're assigned other duties, so you waste time training people who will not get to do what you want them to do. So you have to have that buy-in from the stakeholders, from the district health officials at the government, to allow these health workers to take on this extra skill and task. So
Great.
If you do that, then you're able to retain them.
Wonderful. Thank you so much. And if I'm just going to ask one more question here, and then we'll wrap up, which is my question for Dr. Chowdhary. As you look at the World Health Organization and you look at the Global Fund in particular, do you feel that the Global Fund is open to proposals that include mental health? How receptive do you think that the Global Fund is to these kinds of interventions?
Thanks, David. Yeah, you're putting me on a spot a bit, but I believe that we've started the conversation, and I think that's what's important. This webinar is one such step to reach out to the Global Fund. We know that they have in the past thought about mental health and including mental health in their funding proposals, for example. We know that with this current round of funding, there have been some countries, though albeit a few, who have included mental health and specific activities that they can do to integrate mental health into their funding proposals. So I think we have begun to make some initiatives, and I think we have to just keep reaching out. I think it's on us to keep advocating for this and to keep reaching out and showing that this is doable. There are specific things that can be done. We can have specific indicators to measure how we're doing, and we can have specific, budgetary considerations that we can also put forward that will make our argument stronger. So, yeah.
Thank you very much. Yeah, I think that you really hit it on the head there, because the responsibility comes back to us. What are we doing to move the Global Fund in this direction and help the Global Fund adopt these strategies? The Global Fund is developing its new multi-year strategy. They're still open for comments on that on their website. And next year they have the partnership fora, which I hope many in the audience will be participating in. Check out the Global Fund website for information on that. We can influence the fund. So let's influence the fund to do even more in this area. Thank you for everyone for joining this important discussion. Today, the recording and the notes of the session are going to be posted online at unitedgmh.org/news very shortly. So do check the website. All the references that you need in terms of the documentation, the studies that were referenced. Look at the notes that are coming out on that. You'll find a lot of the references that you need there. The next session will be at the same time on November 24th. So mark that on your calendar today, November 24th, and you can register online at unitedgmh.org. That's the United for Global Mental Health website to join and to submit questions in advance. So that's the session for today. Thank you very much to all of the panelists and to all of the members of the audience who sent in your questions. Thanks very much, everyone.
Thank you, David.
Thanks, David.